We are live now.
Good evening, friends. A very warm welcome to everyone this evening for the masterclass on breast cancer. And keeping in tradition of the masterclasses, we are back with an agenda which is very contemporary, interesting, and will update lot many things regarding breast cancer. We are back in the new year after the winter chill, and I hope we continue the enthusiasm through the year with more topics on varied topics and a variety of cancers, discussing what is the update. Today's program, as you see on this slide, spans both the targeted drugs, hormonal therapies, and a variety of targeted drugs we are going to talk about. And no symposium, no conference today is complete without talking about the checkpoint inhibitors, the understanding about the resistance to the newer drugs and the emerging drugs, and the drug antibody conjugates. And here we are discussing all that is new in the space of breast cancer. I take this opportunity to thank all the faculty, the panelists, for agreeing to be on the program, for energizing our efforts, everyone at Mice Ideas, Rajesh ji and his team, for the hard work they have done at the back end, made sure that the program reaches as many as possible. And that's the reason in each master class, we get hundreds of people from across India and from many parts of the world who join in to listen to these programs. We have a very eminent faculty who will be discussing all this. And I also take this opportunity to thank Om Mishra for his untiring efforts, for making us believe every time that we can do it, and then supporting us in our endeavors. Thank you once again. Over to you, Anshika, to continue the proceedings further.
Thank you
Thanks,
so much.
everyone, and take care.
Thank you so much, sir, for your kind words. With this, let us start our first talk. And for that, I would like to invite Dr. Ankur Varshne. He is a consultant in the Department of Medical Oncology, Medanta, Gurugram, and he's going to speak on phase 3 trial of neoadjuvant uh, pembrolizumab versus placebo plus CT, followed by adjuvant pembrolizumab versus placebo plus ET in high risk ER positive, HER2 negative EBC. Over to you, sir.
Hmm. Hi, good evening, everyone. Anshika, there is certain difficulty in moving the slides. Can you move my slides?
Hello.
Hello.
Sir, I can't see your slides.
Mhm. There's something difficulty in sharing the screen.
1 minute, sir. So there will be an option for sharing the slides.
I know, but that is not working, I think. Can you share my slides?
Yes, sir, you can share me, then I will share the slides.
Okay.
Uh,
Okay.
I'll put my mail ID in the chat box.
Okay.
इसमें कुछ नहीं कम ठीक है मुझे देना कम कम के लिए नहीं दिया आपका टर्मिनेट लिखा है
Sir, I shared you my slides, my mail ID. You can share me on my mail.
And now we are starting with the keynote 756. This is a study of phase 3 trial of neoadjuvant pembrolizumab versus placebo plus chemotherapy followed by adjuvant pembrolizumab in patients with high risk ER receptor positive, HER2 receptive early breast cancer. So what is the background of the study? We already know that patients who are endocrine receptor positive and hormone receptor negative, they usually have a better prognosis than other subtypes. And neoadjuvant chemotherapy is usually recommended in these patient population who have a high risk disease. So if we have the previous data of from keynote 5222, where uh, where neoadjuvant pembrolizumab with the use of chemotherapy have shown the increased PET-CR rates and event-free survival rates as compared to the placebo plus chemotherapy. And keynote 756, this is an ongoing phase 3 study, which is incorporating the use of neoadjuvant pembrolizumab plus chemotherapy in patients who have in patients followed by adjuvant pembrolizumab versus placebo in patients who have high risk ER positive, HER2 negative early breast cancer. So this has shown that neoadjuvant pembrolizumab significantly increases the PET-CR rates, which is irregardless of PD-L1 expressions. And there are study reports that PET-CR rates have increased across various patient subgroups. So next slide. So keynote 756, this is an international open phase 3 study where patients with high risk grade 3 invasive ductal cancers which are ER receptor positive, and high risk is defined by tumor which is greater than 2 centimeter in size or involvement of lymph nodes. So either N1 or 2 or T3, T4 who have not received prior treatment, and they are stratified in two risk groups to receive pembrolizumab plus chemotherapy or either chemotherapy without pembrolizumab. And this is later on, these were stratified with the use of PD-L1 level, nodal involvement, ER positivity, and use of anthracycline schedule. So in the neoadjuvant phase, the test arm has used pembrolizumab 200 milligram per meter, 200 milligram every 3 weekly for 4 cycles, along with paclitaxels, and this for 12 weeks, along with 4 cycles of pembrolizumab with chemotherapy, preferably an anthracycline containing regime. In the placebo arm, the use of 12 weeks of paclitaxel along with 4 cycles of chemotherapy was there. Dose-dense chemotherapy was permitted. After completion of neoadjuvant phase, all the patient went for surgery. And after surgery, the patients who were in the test control arm received pembrolizumab were again have received adjuvant pembrolizumab 200 milligram every 3 weekly for 6 months and endocrine therapy for 10 years. While in the placebo control arm, only endocrine therapy for 10 years were used. Primary endpoints were use of PET, defined as the PET-CR and event-free survival. Secondary endpoints of this study were overall survival, the PET-CR, and the later on subgroup efficacy in the PD-L1 as per the stratification of PD-L1 levels and safety analysis. Next slide, please. We see the baseline characteristics. So median age group was 49. If we see the median PD-L1 level, then approximately 75% have a PD-L1 positive patient population in both the cohorts. And if we see high PD-L1 expression, this high PD-L1 expression greater than 10 was found in 39% patients in the test arm and 40% in the control arm. Majority of these patients have stage 2 or stage 3 disease. Anthracycline schedule was dosed, earlier discussed that dose dense was allowed. And if we see, they predominantly had a T3, T4 disease, and nodal positivity was present in approximately 90% in the pembrolizumab arm, and same in the control arm. ER positivity was present in 94% population in the pembrolizumab arm and 93% patient population in the placebo arm. Next slide. So we see at the first interim analysis with what was the response to the PET-CR rates, and we see that PET-CR rates was achieved in 24% of patients in the pembrolizumab arm, and in the placebo control, it was only 15% of the patient population received this PET-CR rate. So the difference in the population was 8.5%. And the same, if we continue any nodal disease gone, it was considered in 21% of patient population, while in the placebo control arm, it was only 12.8. The difference was again 8% in the results. And if we see the absence of primary disease, then it was in 30% of patient population at the localized site in pembrolizumab arm, and in the placebo control arm, it was only 18.2% on populations. So after this events were observed at the end of 10 months of last randomization, and after a median follow-up of 33 months. Next slide. So if we see the detailed results from the first interim analysis at the end of PET-CR, we see the advantage of achieving PET-CR was pronounced in both the stages, stage 2 and stage 3, and the advantage was present in both the cohorts, in the who were having either lymph node positive or lymph node negative. Though the difference is more pronounced in the patient population who were having clinically node involvement at the baseline, and we see in the patient population who have clinical node involvement at baseline with the use of pembrolizumab, PCR was achieved in 25% of patient population, while in the placebo control, it was achieved in only 16% of patient population. In patients who didn't have clinical node involvement at baseline, PET-CR was achieved in 16% of patient population with the use of pembrolizumab, or while with the use of placebo, it was found only in 13% of patient population. So we see this is the cohort where lymph node positive, the difference was found to be statistically significant. And if we see the reasons, then we see that the European countries and European Caucasian populations usually have a significant difference, and PET-CR was achieved in 29% of patients with the pembrolizumab, while in placebo control arm, it was only 16% of patient populations. So if we see this risk stratification and advantage as per the PD-L1 level, then the differences are as on the expected line. If we see a greater CPS level, then the responses are greater. So in the patient populations who were having a PD-L1 level negative, the pembrolizumab arm PET-CR was achieved only in 7.2% of patient population, and in placebo control it was 2.6. So the difference is only 4.5%. While with the levels of increasing CPS percentage in patient population who have CPS greater than 1, so with the use of pembrolizumab, PET-CR was achieved in 29% of patient population, while with the use of placebo, it was achieved in 19% of patient population. With the use of CPS greater than 10, the PET-CR rates with the use of pembrolizumab was 42%. With the use of placebo, it was 29%. If CPS was greater than 20, high expression of PD-L1, we see the PET-CR was achieved in 53% of patient population with the use of pembrolizumab, while with the placebo, it was only 36%. So the difference we found in the CPS greater than 20 is 17.4%, and in CPS greater than 10, it is 13.2%, which is numerically, and I found very significant. Next slide, please. So we see the update from the analysis as per the risk stratification, and we see in the patient population who have a CPS greater than 1, and ER was low positive, less than 10%, we see a PET-CR was in 57% of patient population as compared to placebo where it was 33%. So this is a repercussion from the already existing data where it is the data with the use of pembrolizumab have already shown significant difference in the triple negative patient population. Coming to the ER positivity greater than 10%, The best CR was achieved in 27.6% patient population with the use of pembrolizumab arm, while it was achieved only 18.4% of patient population with the placebo arm. The difference was found to be significant, and if we see in patients who have ER positivity less than 10%, we see that the estimate difference with the use of pembrolizumab was found to be 24.2%, while with the use of ER positivity greater than percent, it was 9.2% difference is noted. So if PDL1 is less than 1, ER is positive, we see the use of pembrolizumab, the PET-CR achieved rates are 7.2%, while with the use of placebo, it was only 2.7%. So if we see the use the data from the chemotherapy exposures, so the patient population who have achieved full doses of chemotherapy with the use of pembrolizumab arm, PET-CR rates achieve are 26%, while with the placebo arm, it is only 17%. In patient who doesn't have full exposure of chemotherapy, so the PET-CR rates with the use of pembrolizumab arm, it is 13.2%, while with the use of placebo, it is 6.4%. Next slide, please. So if we see residual cancer burden after definite surgery, so in residual cancer burden, which is 0 to 1, we see a pembrolizumab have a rate of 35% as compared to the placebo. In residual cancer burden 2, it is 40% versus 45%, while if we see residual cancer burden 3, it is 20% with the pembrolizumab arm and only 28.9 months with the use of placebo. So we see that with the use of pembrolizumab, there is a lesser evidence of residual cancer burden. Next slide, please. Now the significant question comes, with the use of immunotherapy, there comes the increased side effects, and majority are immune-related side effects. So if we see immune-mediated side effects, as expected, this were more in the pembrolizumab arm, which was 32%, while in the placebo control arm, it was only 7%. But if we see the serious adverse events, grade 3 to 5, it was 7% in the pembrolizumab arm, it was 1.2% in the placebo control arm. Though there was no deaths reported to the use of immunotherapy, but there was 7% of patients who have to discontinue drug because owing to adverse events, while in the placebo, it was only 2% of patient population who have to discontinue the drug. And if we see the major adverse events, hypothyroidism, and other lists of events were less reported. Next slide, please. Next slide, please. So what were the investigator concluded? The investigator concluded that in patients who have a high risk, endocrine receptor positive, HER2 receptor negative early breast cancer, neoadjuvant pembrolizumab with the use of chemotherapy have known led to improved PET-CR rates as compared to the placebo, and this difference was found to be statistically significant, 24% versus 15%. So this improved PET-CR rates we have already observed in the TNBC group, and this in the ER positive group, this this difference was significant, and this was found across all the subgroups. This was in all the subgroups, which include the patient population division by the regions, disease stages, baseline lymph node involvement, and PDL1 expression levels. And as I already discussed, the greatest benefit was observed in patients who have node positive disease at baseline and with the higher PDL1 expressions, and in those patients who have ER low tumor expression. Lower PET-CR rates have been observed in patients who have received less dose of chemotherapy, although in this patient population, pembrolizumab is associated with improved PET-CR rates. Patients who have, with the use of pembrolizumab, have moved to lower category of residual cancer burden, and usually the toxicities are similar, which have been already known in various clinical trials. And the EFS data is not mature and require more time to be discussed. Next slide, please. So I conclude my presentation. Thank you.
Thank you, Thank you so much, sir, for such an informative talk. Now, moving ahead to our next talk, I would like to invite Dr. Murtaza Bohra. He is a consultant in the Department of Medical Oncology at National Cancer Institute, Nagpur, and he will be speaking on navigating endocrine therapy and resistance in ER positive, HER2 negative breast cancer. Over to you, sir. For some personal reasons, Dr. Murtaza is not available. We'll take his talk in the last. And moving ahead, I would like to invite our next speaker, Dr. Gaurav Gupta. He's an ex-professor and head in the Department of Medical Oncology. He's a director at Optimize Oncology Center, Lucknow, and will be speaking on phase 2, Debutecan, D, DEBBRA, tri, try to trastuzumab, Durextecan in cohort with HER2 positive, HER negative low ABC and leptomeningeal carcinomatosis. Over to you, sir.
Hello, good evening. Let me just try and share my slides. I think I'm audible. Hello, can you hear me?
Yes, sir, you are audible.
Okay, just hold on. I will try and share the slides.
Yes, sir. If you want, we can share your slides. So should I share your slides? Sir, is that okay?
Hello.
Hello.
Yeah. Is my screen visible now?
No, sir.
Just a minute.
Yes, sir, it's visible now.
Yeah. Is this fine?
Yes, sir.
Okay, fine. So, a very warm welcome to all the delegates and special thanks to the organizers for giving me the opportunity. So I'll be presenting the phase 2 DEBRA trial, which was presented at SABCS 2023. This is a phase 2 study of trastuzumab deruxtecan in cohort 5. That is a cohort with HER2 positive or HER2 low advanced breast cancer and leptomeningeal carcinomatosis. So let's go and see what were the findings. So as I said, it is the cohort 5 of the DEBRA trial. And to just give a brief background, approx 5 to 10% patients of advanced breast cancer develop leptomeningeal carcinomatosis, and probably this number is going to increase with the availability of so many effective treatments which have led to improvement in survival of advanced HER2 positive breast cancers. Unfortunately, leptomeningeal disease has very limited treatment options and an extremely grave prognosis. There is a median overall survival of 4 to 6 weeks if it is untreated and 3 to 6 months if it is treated. And TDXD now is a HER2 directed ADC, we all know, and it is being approved for multiple indications. And retrospective data suggests durable anti-tumor activity in case series with HER2 positive advanced breast cancer and leptomeningeal disease. However, the data is lacking for HER2 low and leptomeningeal disease patients. So it was a multi-cohort phase 2 trial which evaluated TDXD in patients with pre-treated HER2 positive or HER2 low advanced breast cancer with CNS involvement, including brain mets, that is the solid mets, or leptomeningeal disease. The current analysis reports the safety and efficacy in the small cohort which had HER2 positive and HER2 low disease, advanced breast cancer with pathologically confirmed leptomeningeal carcinomatosis. So this trial was conducted in Portugal and Spain, and the data cutoff date was April 4th, 2023. Cohort 5 consists of adults with HER2 positive or HER2 low metastatic breast cancer and leptomeningeal disease, which was defined as positive CSF cytology findings, that is LMD type 1. If HER2 positive, the patient could have taken prior taxane-based treatments and one or more line of HER2 targeted treatment for metastatic disease was permitted. If it was a HR negative and HER2 low disease, more than one prior chemotherapy for metastatic disease was permitted. If HR positive but HER2 low, one prior line of endocrine therapy as well as greater than one prior line of chemotherapy for metastatic disease was permitted. ECOG PS, which was allowed, was 0 to 2. The numbers are quite small. Total number of the trial participants or the study group was 7 only. These patients received trastuzumab deruxtecan at a dose of 5.4 mg per kg IV on day 1 every 3 days. Treatment continued until progressive disease, unacceptable toxicity, or withdrawal of consent. The primary endpoint for this particular cohort, that is the cohort 5, was overall survival. The planned sample size had a power of 80% with nominal one-sided alpha of 0.05 in each cohort. Cohort 5 used one-sided maximum likelihood exponential test with null hypothesis of median overall survival less than 2 months and the alternative hypothesis or the test hypothesis of median overall survival of greater than 6 months. Secondary endpoints were PFS, overall response rate, clinical benefit rate, duration of treatment, etc., etc. And there were other exploratory endpoints. Coming on to the baseline characteristics, as I said, there were 7 patients in total. Median age was 57 with a range from 42 to 69. Almost 40% patients were ECOG PS0 or asymptomatic. More than a quarter were having ECOG PS of 1 or 2. Measurable systemic disease at baseline was present intracranially in 1 patient and extracranially in 3 patients. The number of metastatic organ sites involved other than the leptomeningeal disease was less than 3 in 6 patients. However, 1 patient had more than 3 sites of extra leptomeningeal disease. HER2 status was positive in 3 patients and 4 patients had HER2 low disease. HR status was ER positive or PR positive in 5 patients. Median number or prior lines of treatment for advanced disease ranged from 1 to 8 and the median was 4. So this is a very heavily pre-treated group. Median duration of last prior treatment was 1.9 months with a range of 0.7 to 15 months. So we can see they generally had poor outcomes with prior therapies, except for probably 1 patient who may have been an outlier with a 15-month duration post last treatment. Prior systemic anti-cancer treatments were anti-HER2 therapy in 3 patients, chemotherapy all 7 patients had received, and endocrine therapy in 2 patients. The point to notice that no patient had received prior whole brain RT, SRS, SRT, or surgery for CNS disease. So they were naive for CNS disease treatment. And all patients were Spanish sites. Coming on to the OS and PFS, the median OS was 13.3 months with a range from 2.5 months to not reached. At 16 weeks, that is 4 months, 86% patients were alive. At 24 weeks, 71% were alive. And OS events occurred in 5 out of 7 patients. PFS was determined as per the RANO-BM and the RECIST criteria both. Median PFS was quite good at 8.9 months with a range from 2.1 months to not reached. 4-month PFS or 16-week PFS was 86%, and again 24-week PFS was 71%. This cohort analysis met its primary endpoint of OS, the median OS of 13.3 months with a 95% confidence interval of 2.5 months to not reached and a p-value of less than 0.001, and the median follow-up was 12 months. So there was a reasonable median follow-up, and median OS is quite good. And it is quite consistent with the experience with TDXD in other patients and in other cohorts of brain disease. So best response for intracranial, extracranial, and overall lesions. So as per the best response is concerned, one patient had intracranial CR, stable disease lasting more than 24 months, intracranially occurred in one patient, extracranially occurred in 2 patients. Non-CR, non-PD at 24 weeks was seen in 2 patients intracranially and in 3 patients extracranially. Non-CR, non-PD at less than 24 weeks, for less than 24 weeks was seen in 1 patient and 0 patient extracranially. Progressive disease in the brain notably occurred in none of the patients. So, implying that the intracranial control of the leptomeningeal disease was excellent. Overall response rate was 1 out of 5, that is 20% for intracranial disease, 0 out of 6, that is 0% for extracranial disease. That means all the patients had extracranial progression rather than intracranial progression again. And the clinical benefit rate for intracranial disease was 80%, for extracranial disease 83%, and for all lesions it was 71.4%. Prolonged stabilization, that is greater than 24 weeks per RECIST, was observed in 5 out of 7 patients. And as I had mentioned, 1 patient had an intracranial CR as per RANO-BM criteria with negative CSF with extracranial lesions persisting, and he had non-measurable disease at baseline. At the time of treatment failure in the 5 patients with progressive disease, none had intracranial progression or worsening leptomeningeal symptoms. As far as the safety and profile goes, it was reasonably safe considering the heavily pretreated group. Hematological toxicity occurred in 1 patient, and that was thrombocytopenia. Non-hematological toxicity grade 3 was seen in 3 patients. It was nausea, and 1 patient had gamma GGT elevation. Apart from that, any grade toxicity was seen in all the patients. Hematological toxicity, anemia, thrombocytopenia was seen in 3 and 2 patients respectively. And the other toxicities like nausea, headache, fatigue, they were all seen in almost 40% patients. So median duration of treatment was 9 months, which ranged from 2.1 to 18.6 months. 2 patients remained on treatment at data cutoff. There was no treatment-related death. Serious or unrelated treatment-associated adverse events occurred in 4 patients, that is 57%. 1 related serious event had occurred, that was grade 3 nausea. There was no ILD, no pneumonitis. So the investigators concluded this analysis of small cohort from DEBRA met its primary endpoint of OS in 7 patients, all the 7 patients with HER2 positive or HER2 low advanced breast cancer and pathologically confirmed leptomeningeal disease treated with TDXD. Median OS of 13.3 months, which is quite unheard of in this setting. No new safety signals were observed, and they concluded that TDXD is associated with promising activity in this setting, and additional studies needed in large cohorts to validate this activity. With this, I will thank you for your precious time and hand over the dais back to the organizers.
Thank you so much, sir, for such an educative talk. Moving ahead to our next talk, I would like to invite Dr. Vaibhav Chaudhary. He is a consultant in the Department of Medical Oncology at Kokilaben Dhirubhai Ambani Hospital, Mumbai, and he is going to speak on Tropion Breast 1, efficiency and safety from phase 2. 1 minute, sir. Efficiency and safety from phase 3 trial of Dabatomab deruxtecan versus chemotherapy for patients with previously treated HR positive, HER2 negative ABC. Over to you, sir.
Yeah, good evening, everyone. I hope my screen is visible.
Yes, sir, it's visible.
Yeah. So, good evening, everyone, and thanks for giving me this chance to actually speak on this very important study, Tropion Breast 01. This basically is an unmet need because, as we all know, that all the hormone receptive breast cancers, metastatic breast cancer, actually evolve into a hormone refractory, and we are forced to give chemotherapy to them once the hormone therapies fail. So there are physician's choice. There are many choices after third line, fourth line, fifth line, and ultimately at that time, patient also is fragile. There are comorbidities. There is actually very difficult to give them full dose of chemotherapy, and it was an unmet need. So now this antibody drug conjugates are exploring this horizon where actually they can work on it to minimize the toxicity, make the chemotherapy more acceptable, and give chemotherapy in a form which is targeted basically. And that's how this study actually, this drug, datopotamab deruxtecan, was developed like other ADCs, like I said, sacituzumab is already approved in this kind of a setting. So Tropion Breast 01, it actually studied the efficacy and safety from phase 3 trial of datopotamab deruxtecan chemotherapy for patient with previously treated hormone receptor positive but HER2 negative advanced breast cancer. So this is what the background is. Most patients with endocrine resistant ultimately subsequently receive chemotherapy, and they are actually having more toxicities because the chemotherapy comes down later in the line. There was an unmet need, and Dato-DXd is TROP2 directed ADC, which is topoisomerase inhibitor with topoisomerase inhibitor payload. So essentially, the average drug to antibody ratio here is 4, and the Dato-DXd is internalized into tumor cells and translocated to lysosomes and released it to release the payload. So this is about the phase 3 study comparing Dato-DXd versus chemotherapy, investigator choice chemotherapy in patients with previously treated HR positive, HER2 negative metastatic breast cancer once they become hormone refractory. So the primary results demonstrated significant improvement in PFS with a hazard ratio of 0.63. Overall survival data still immature, and current analysis reports the additional efficacy, safety, and the quality of life data. So this is the study schema where it is a global randomized open label phase 3 trial. Patient with HR positive, HER2 negative, inoperable, or metastatic breast cancer previously treated 1-2 lines of chemotherapy. So this further down the line, and who have actually progressed on ET or are unsuitable for endocrine therapy. So quite a good number, 732 patients, were evenly divided into Dato DXd 6 mg per kg every 3 weekly versus investigator's choice chemotherapy until progressive disease or unacceptable toxicities. It had a dual primary endpoint of PFS as per RECIST, as per BICR per RECIST, and OS, and the secondary endpoint of ORR, PFS by investigator, DOR, DCR, TFST, TSST, and PFS2. Also, safety is very important. So this is what they found out as far as the efficacy is there. The median progression-free survival was 6.9 months as compared to the investigator choice chemotherapy with a hazard ratio of 0.63. Similar trend was observed by the investigator as well, where the hazard ratio was 0.64. And again, the overall response rate, that is most important, because in this condition, most of the patients end up being symptomatic. They might have massive pleural effusion, they might have multiple bony metastasis, or some physical uh, discomfort because of the tumor mass, tumor volume. So this overall response rate in this setting is very, very meaningful. Like if I treat almost 100 patients of such patients with DATO-DXD, I'm quite convinced that in some fourth line, fifth line, sixth line setting, I would be getting around 36.4% of overall response rate. That's quite impressive in this setting. And versus the investigator choice chemotherapy, it is 23%. So it's almost 1.5 times of, or even more than that, of what we achieve by, we used to traditionally achieve by our traditional chemotherapy. So the different subgroups where they studied, basically they looked at the brain metastasis versus no brain metastasis, and the results were actually quite impressive even in brain metastasis patient. Though the brain metastasis patients were only 35 in DATO-DXD and 23 in the chemotherapy arm, but there also there was a hazard ratio of around 0.73, and there actually they did better as compared to chemotherapy, because we know a lot of chemotherapy drugs don't have that great intracranial activity, and where DATO-DXD actually scored over them. And also there was another subgroup where the progression survival by CDK4/6 inhibitor duration was less than 12 months and more than 12 months. So here, as we can see over here, that regardless of the progression survival on the CDK4/6, because this criteria we use mostly to identify the poor prognosis subgroup, like those who progress within 12 months of CDK4/6 inhibitor start with endocrine. We actually consider that those patients have an aggressive biology, and then they will not respond better to chemotherapy as well. So there also this hazard ratio was 0.61, and the PFS was 6.9 as compared to 4.2. So yes, investigator choice chemotherapy had inferior progression survival there in this specific subgroup, and also in the brain metastasis. So these are two important subgroups with poor prognosis, and in poor prognosis subgroups also the DATO-DXD actually has proven to be better than the investigator choice chemotherapy. And whenever a new drug is introduced, a new complicated drug, antibody drug conjugate is being introduced, we are actually worried about the safety, because these patients are fragile. These patients are difficult to treat. They might have a lot of comorbidities as well. And the treatment related adverse events, actually, they were, as we all know, that these are better drugs, these are newer drugs, these are engineered drugs to decrease the collateral damage. Most of the collateral damage by chemotherapeutic drugs is because of non-specific cell kill. And that actually leads to a lot of myelosuppression, like neutropenia and all. As here you can see that there was actually a very less amount of neutropenia in DATO-DXD subgroup of all grades of almost 11% versus 42%, and also leading to dose interruption 0 versus 17%. And GCSF was also required in very less amount of number of patients where DATO-DXD was given as compared to the cytotoxic chemotherapy. And this is actually expected, because this is basically a bioengineered molecule where we actually focus on targeting the tumor cells itself rather than giving something which actually has more of a collateral damage. And the chemotherapy, yes, they are old. The newest chemotherapy drug which we use in this setting is actually eribulin. That also leads to substantial amount of myelosuppression in these heavily pretreated patients. So that's why it's a no-brainer that, yeah, it's a safer drug as far as neutropenia and myelosuppression is there. Stomatitis, yes, the stomatitis rates were higher because it's a class effect of these drugs, but that can be managed. And as we have learned over the time, like PIK3 blockers or mTOR blockers like everolimus, if we manage the stomatitis and all that, we have to basically give them a supportive care and maybe certain dose reductions if required. So that is there, and it's kind of a class effect of this drug that the stomatitis all grades were actually much higher as compared to the chemotherapy. All grades treatment related adverse effect, and basically none of the treatment related well led to discontinuation more than 1% in each of the arms. And most common TRAEs leading to dose interruption with Dato-DXd were infusion-related reactions, ILD. Yes, with deruxtecan also we have that much of knowledge that yes, ILD might be an issue, and stomatitis, but they were only 1%. And 1% in this heavily treated population is actually a good number. Most common treatment lead to dose reduction chemotherapy, where as expected, neutropenia and leukopenia. So time to deterioration in the global health score and the quality of life, physical functioning, as we can see, and pain again was higher, and actually it was a better tolerated, a well tolerated drug as compared to the old crude chemotherapy. Whatever chemotherapy you give, whatever dose reductions you do, ultimately it leads to a lot of decrease in the quality of life, especially in this setting. May not be true in the first line setting or a second line setting, but when we are talking about hormone refractory patients as well as those who have failed a couple of lines of chemotherapy, then yeah, obviously these patients are fragile, and you have to look into the quality of life, because ultimately we are not promising cure, we are not promising a very good, very big difference in the quantity of life. So ultimately it's your duty to look into the quality of life parameters, and yes, this quality of life parameters actually is heavily skewed in favor of the Dato-DXd, as we can see that the hazard ratios over here are actually favoring in all the aspects, like the quality of life, global health scale, functioning, pain, as well as the first instance of pain and confirmed all pain. Again, Dato-DXd was better in improving the quality of life of these heavily pretreated patients. So concluding remarks by investigators' conclusion was that in this analysis, Dato-DXd was associated with improved progression survival versus the chemotherapy of physician's choice, regardless of prior duration of CDK4/6 and regardless of presence and absence of brain metastasis. Time to first subsequent therapy was longer with Dato-DXd. Safety profile with Dato-DXd was favorable, with fewer grade 3, more than 3 TRAEs, dose reductions, and dose interruptions versus ICC. Treatment-related stomatitis with Dato-DXd was generally lower grade with few dose interruptions and reductions. Time to deterioration of quality of life was longer in Dato-DXd. And also, with this, the investigator concluded that Dato-DXd is potential new option for patients with previously treated endocrine-resistant, HR-positive, HER2-negative metastatic breast cancer. Thanks a lot for patient listening. Now we may proceed.
Thank you so much, sir, for such a great talk. Now, moving ahead, I would like to invite our next speaker, Dr. Murtaza Bohra. He is a consultant in the Department of Medical Oncology at National Cancer Institute, Nagpur, and he is going to speak on navigating endocrine therapy and resistance in ER-positive, HER2-negative breast cancer. Over to you, sir.
Thank you. First of all, I would like to thank organizers for providing me this opportunity to discuss about the novel advances in the field of oncology, especially in the breast cancer, with all my colleagues and seniors. So without wasting much time, I will start my presentation. Is my screen visible?
Yes, sir, it's visible.
So as my topic is the navigating endocrine therapy and the resistant in the ER-positive, HER2-negative breast cancer. This is the most common, one of the most common subset of the breast cancer, as we are dealing routinely in the OPD. Hormone positive, HER2 negative. Almost we can say 50 to 60% patients are hormone positive, HER2 negative. As we see, generally these type of patients do better compared to the other aggressive variant like triple negative and HER2 positive. But over the time, we are seeing this. There is some resistant mechanism which lead to develop disease progression after a couple of we can say a couple of years or some the time later on the his or her lifespan of the patient. So what are the factors which lead to this resistance and how to deal with in these type of resistance? As we know, we have many special or futuristic molecule in the pipeline to deal with the hormone positive resistance in the patient. As we have CDK4/6 available with us, all three like palbociclib, ribociclib, and abemaciclib in the first line as well as in the second line options with us. So how to choose a specific CDK4/6 in our patients, because we have plenty of data. If you see, the Paloma 2 is for Palbo, Mona Lisa 2, 3, and 7 for Ribo, and the Monarch 3 for the abemaciclib in the first line as well as in the second line as a CDK4/6 along with the hormone therapy agent. All have the PFS range in the between 25 to 27 in the first line and somewhat around 21 to 22 in second line. But we have OS data with significant OS data with only with ribociclib, which is with a hazard ratio of 0.76 to 0.67 with ribo only. We don't have a data of overall survival with palbo, and we have some overall survival data with abema. So we have to choose wisely for our patient depending on his or her comorbidities as well as the patient preference and the disease status. So why all these patients generally develop resistance in the later course of the disease? Most common mutation has been found is ESR1, which is we can say the main cause of or frequently found mutation in the metastatic setting as in the later line. It is very rare in the primary tumor. We can say less than 1% chances of getting ESR1 in the primary tumor, but it's highly enriched in the metastatic breast cancer when the patient have received the endocrine therapy in the first line. So if you see the trial data of ESR1 mutation present detected by the ctDNA method, in Mona Lisa 2, it's only 4% chances of ESR1 mutation in the first line. In Bolero 2 and the Fergie trial and the Paloma 3 and Sophia trial, these are all the second line trial. On second line onwards trial, we have seen the ESR1 mutation in the range of the 25 to 37%. So as the patient progress on first line hormonal therapy, the chances of ER mutation is very high. So we can say it's a one type of acquired mutation in the hormone positive HER2 negative, and it generally leads to the disease progression. So the PADA1 trial, which is for palbo with fulvestrant versus palbociclib with AI in the patient with the rising ESR1 mutation after the patient has received the palbo plus AI. So it is a multi-center randomized open label phase 3 trial where the eligibility criteria is that all the AI sensitive patients with the hormone positive HER2 negative metastatic breast cancer patient with no prior treatment was approved. So the patient is started on palbociclib and the aromatase inhibitor, and the ESR1 mutation is checked at every 2 monthly. So if patient having the ESR1 mutation on a rising trend, then it was randomized between the shifting to the palbo along with the fulvestrant versus continuation of the same treatment. So co-primary endpoint of this study is the PFS in the intention to treat population and grade 3 hematological adverse event. Secondary endpoint is PFS2, chemotherapy-free survival, and the time to study failure from the randomization. PFS from the time to crossover by the investigator. So if you see the Kaplan-Meier curve for this study, is a well separated from the very early course of the disease. It's showing the superiority of this palbo plus fulvestrant combination in the patient, those who have the rising ESR1 mutation level. So if you see the median PFS in the range of 12.8 months with the palbo plus fulvestrant compared to the only 5.8 months with the palbo plus AI, with the very significant hazard ratio, which is 0.54. And the median PFS from the time to crossover is 3.51. So we can say almost 7-month PFS difference if we shift to patient to full strength compared to if we continue the AI along with the PALB. PFS2 is also having a higher side with the Palbo plus full strength in the range of 29.4 months compared to the only 14 months. So almost double the advantage of using full strength with the Palbo combination with a hazard ratio of 0.37. If you see the kinetics of this ESR1 mutation, it shows that at a 2-month, 163 patient has ctDNA result of no ESR mutation with the Palbo plus full strength, which is 68.2% versus only 32.1% with the Palbo plus AI. So that means if we continue with the, if we start patient on the full strength, the rising trend of the ESR1 mutation is subsided. If with the full strength. Now we have other biomarkers also tested like germline BRCA1, BRCA2 mutation. If it is positive, we have olaparib or talazoparib. If PIK3 mutation is found, then we have alpelisib along with the any hormonal agent like fulvestrant or exemestane. ESR1 mutation positive, we have still this drug is not available in India, but we have elacestrant in the future. And the tumor agnostic biomarker like anti-KRK fusion gene, we have larotrectinib or entrectinib. RAT fusion, we have sulfacatinib. And the MSI high or deficient MMR protein, we have pembrolizumab or dostarlimab as an immunotherapy agent. If the TMB is high, we have pembrolizumab for our patients. Now the guidelines for the ESR1 mutation testing. As per the ESCO routine test guideline, the routine testing for ESR1 mutation should occur at the recurrence or progression of on endocrine therapy with or without CDK inhibitors. With blood-based ctDNA assay preferred owing to the higher sensitivity. Serena-6 trial, it is for CDK4/6 inhibitors with the camizestrant or AI in the ESR1 mutation, hormone positive, HER2 negative metastatic breast cancer patient without progression on the first line CDK4/6 inhibitor or AI. So the step 1 is the standard of choice, which is AI plus CDK4/6. Then have to check the ESR1 mutation by ctDNA every 2 to 3 cycles. If it is negative, then continue the same and screen. If ESR1 mutation is positive, then shift it to the camizestrant or randomization to the continue with the same. The primary endpoint of this study is PFS and secondary endpoint of PFS2, overall survival, objective response rate, and the clinical benefit at the 24 weeks. We will see the data, the result of this study in the near future. Now, coming on the main topic of today's talk, navigating the endocrine therapy. What is the optimal sequence and how to optimize the treatment option for ER positive, HER2 negative metastatic breast cancer patients. Now, the question arises, what to do after the progression on the CDK4/6 inhibitor? Should we continue the same or change on the other agents? Like, as we know, the performance of the endocrine monotherapy after the CDK4 inhibitor is very poor. And the role of novel endocrine agents, we don't know. So single agent fulvestrant, the median PFS in the range of almost 2 to 3 months only. Elacestrant, oral SERD, which is effective in ESR1 mutation, we know the median PFS in the range of 3 to 4 months. Serena-2 trial, which is now comparing the fulvestrant along with the camizestrant, we will see how much it is effective when the ESR is mutated. Then Veritech trial, which is for the ARV47 newer molecule still in the pipeline. So is there any role of continuation of CDK4/6 beyond progression? We have 2 trial data. One is maintain and the pace. Maintain is for the ribociclib and the pace is for the palbociclib. So we will see in the subsequent slide what the data is saying for these trials and we should continue the ribociclib or palbociclib in the beyond the progression or not. So tackling endocrine resistant, we know the most common pathways which are mutated is the PIK3 AKT mTOR pathway. So we have Bolero 2 trial data for the everolimus along with the exemestane combination. In the BILIVE study, which is for the alpelisib along with the fulvestrant beyond CDK4/6 also, and Captello study, which is our capivasertib along with the fulvestrant versus fulvestrant alone. So if we see the data of the phase 2 maintain trial of addition of the ribociclib to the endocrine therapy after the progression on the CDK4/6 inhibitor along with the endocrine therapy in hormone positive HER2 negative metastatic breast cancer, the patient has continued on the ribociclib and switched to ET, which is endocrine therapy, depending which endocrine therapy were used in the prior versus endocrine therapy alone. The primary endpoint of this study is the progression-free survival, and the key secondary endpoint is objective response rate, clinical benefit rate, safety, and the tumor response. So if we see the Kaplan-Meier curve for this study, the curves are well separated. That very starting, or we can say early course of the disease, showing the superiority of the experimental agent compared to the standard of care. If we see the median PFS for the ribo along with the ET is in the range of 5.29 months compared to the ET alone, which is 2.76 months with a hazard ratio of 0.7. That means this combination is well efficacious compared to the ET alone. But if we see this, if we dissect this data and the subgroup analysis, it has been seen that those patients, those who are ESR1 wild type, they have got the majority of the benefit of the continuation of the ribociclib along with the endocrine therapy compared to those who have the ESR1 mutation. That means if the patient has the progression because of the ESR mutation, ribo will not as much as helpful as in the ESR1 wild type. And the overall response rate is also increase if we continue the ribociclib compared with the endocrine therapy alone. Clinical benefit rate, that means the CR rate, PR or stable disease rate is also higher with the ribo compared to the placebo or ET alone. Now the PACE trial, which is for palbociclib along with the fulvestrant after the progression, it has a 3-arm. One is the fulvestrant plus palbociclib, another is palbo plus fulvi and the avelumab, which is immunotherapy adding in this trial, and the fulvestrant alone. The primary endpoint is the PFS. The secondary endpoint is the objective response rate, safety, and outcomes in the predefined molecular subgroup. So if you see the Kaplan-Meier curve for this study, almost the similar responses with all the agents, but the maximum advantage is with the red curve, which is for the fulvestrant plus palbo along with the avelumab. The highest median progression-free survival is the 8.1 month compared to the 4.6 versus 4.8. So adding palbo in fulvestrant is not much helpful if we add avelumab also with a hazard ratio of 0.75. So what is the mechanism? We have to see. It is a question of research, but still the immunotherapy has worked in particular in this type of segment of the patient compared with the CDK4/6 and endocrine therapy alone. In the subgroup analysis of the SPACE study is also favors in majority of the patients with the fulvestrant along with the palbociclib, but like if the PIK3 mutation is wild type, then it favors the fulvestrant alone. Then another is the post-MONARCH trial, which is the fulvestrant plus abemaciclib after the progression or recurrence on the CDK4/6 inhibitor and the endocrine therapy. Similar, the one arm consists of the abema plus fulvestrant, and another arm consists of the fulvestrant alone. Primary endpoint of BFS, and second endpoint is overall survival and the objective response. Another study is the Capitello 291, which is the capivasertib versus fulvestrant alone in the AI resistant AI resistant hormone positive HER2 negative advanced breast cancer. There's a two arm consist of the capacitive plus fulvestrant versus fulvestrant alone. The primary endpoint is the PFS and the second endpoint is the overall survival as well as the objective response rate. So if you see the Kaplan-Meier curve, the curves are well separated, showing the superiority of the capivasertib combination with the median PFS in the range of 7.2 months compared to the only 3.6 months with the fulvestrant alone. So almost double the advantage of adding capivasertib with the fulvestrant compared to the fulvestrant alone. So with a hazard ratio of 0.60. In investigator assess the PFS in the AKT pathway altered patient is am I audible? Hello?
Yes, sir, you're audible.
Hello?
Hello. Yes, sir, you're audible.
Sorry for interruption. So, if you see those patients who have the altered AKT pathway also responded with the capivasertib compared to the placebo, with the median PFS 7.3 months versus 3.1 months with the fulvestrant alone, with a hazard ratio of 0.50. That means all the patients those have altered AKT pathway getting more advantage if we add the capivasertib along with the fulvestrant. It is now approved by FDA. The indication of in the hormone positive, HER2 negative, locally advanced or metastatic breast cancer patient with one or more PIK3 alteration, like AKT1, PTEN, or PIK3CA, detected by approval test on the progression of at least one line of the endocrine based regime. Capitilo 291 OS studies also having numerically on a higher side with the capivasertib, but still data yet to be mature. Safety, we know every drug has its own side effect, so it is also true with the capivasertib also, but it's quite manageable. And this safety profile is also compared with the other AKT pathway altered drugs. Most common side effects are diarrhea, rash, nausea, fatigue, hyperglycemia, stomatitis. Inavo 120, which is palbociclib plus fulvestrant with or without inavoslip, which is previously untreated hormone positive, HER2 negative advanced breast cancer, where the inavolisib is added with the fulvestrant along with the palbociclib, compared with the palbo plus fulvestrant combination. And the eligibility criteria of this study is the patient with the hormone positive, HER2 negative, PIK3 mutant, locally advanced or metastatic breast cancer without any prior therapy for locally advanced or metastatic setting. Progression less than 12 months of adjuvant endocrine therapy or miserable disease with the patient should not have any diabetic range, random plus 2. Primary endpoint of this study PFS, and secondary endpoint is objective response rate, duration of response, and the clinical benefit and the overall survival. We will see all these data in the near future. It will help us in sequencing our agents or the hormonal agents or available target therapy agents for our patients for the better overall survival and the median progression-free survival. With this, I would like to thank you, all of you, for the patience listening. If you have any question or any doubt, you can ask.
Thank you so much, sir, for such an amazing and interesting talk. Now, moving ahead to our discussion, I would like to invite Dr. Deepak Bharti, Dr. Deba Dulal Biswal, Dr. Vaibhav Chaudhary, Dr. Gaurav Gupta, Dr. Murtaza Bhora, and Dr. Ankur Varshney. Over to you, sir.
Hello, good evening, everyone. Hello, good evening. Start. Okay.
I can hear.
Okay, so myself, Dr. Deepak. So I think most of the things has been covered in the last 3-4 talks, but I just want to highlight 2-3 points in all the 4 aspects regarding TDXD. I think most of the Destiny trials have overcome the data, and they have shown that it work wonder in the brain metastasis patients, and we have phase 3 trials also. So we don't need any phase 2 trial regarding the LMC or other way around. And regarding CDK4 inhibitors, and we know that we are starting with palbociclib, then ribo, and then abema is there to take care of things. Although we have a challenge that the patient who get progressed on CDK4 inhibitor in first go, whether we can re-challenge them or not. And we have the well-known phase 3 data regarding abema. We know that previously anyone that progressed on palbo and ribo, we can shift the patient to abema after the failure of one CDK. But as the trial of PACE and this maintain has shown that we can re-challenge the same CDK with the change of endocrine therapy backbone. And I think more and more study will come out, and we can reuse the thing in future slides. And regarding that 7 patients of TDXD, I think that is very less number to comment on the things, and I think things will come in a better way, and with good number of cohort patients will be there, and we can judge the patient to that extent. And regarding the trial which we have shown, that the DABA trial, and we shown that the patient like we see in all trastuzumab or TDM cases, that all PCR are not converting to OS. And similar in DEBA patient, although are getting the good number of PCR, they are achieving the things, but I don't think that they will get convert into a OS benefit. And if the data will come, then we are going to use this thing. And the trial of regarding Pembro 756, as 522 is work wonder in TNBC group, but I think it's too early to shift over to Pembro in hormone positive cases. And I think more and more data to get mature enough, and we can make it wiser to use 756 in our routine practice. These are certain points I want to highlight regarding the in all the trials we have discussed.
So anything among the speakers, any more comments?
Yeah, comments wise, actually, this inavolisib trial actually may be a game changer, because we know that PIK3 is a big problem, and we are not testing ER positive tumors because we have wonderful hormone therapy. CDK4/6 works across the board. So, but then those patients who actually progress file on and adjuvant endocrine therapy, there actually it is worthy to test for this PIK3. And as inavolisib, basically it's a first line study where they have introduced that blocker along with palbociclib and ET. So that might be a potential game changer. Maybe in the times to come, there might be a subset. There is around 25 to 30% of the patients who are PIK3 block mutated, and that's not an acquired mutation. They have it since the inception. In fact, all of the breast cancer, even triple negative, also they have. I happen to have capital 2, I think 292 with me. It was a study of upfront paclitaxel plus capivasertib. Somehow the results are not positive, but this study is positive, 291. Proof of pudding, basically, that yes, the activity of PIK3 blockers is there, and with chemotherapy it can be increased. And taking it one step further, even if we introduce in first line, we might have a good prognosis for this poor prognostic subgroup of PIK3, P10, AKT, that whole axis actually, not only PIK3, but then the whole axis. So that's what my take is, that yes, it's very exciting. This was just presented in this year's SABCS, and then the future follow-up of this study and certain this focusing on this principle actually will lead to us to somewhere where actually we will not be treating all hormone receptor positive metastatic breast cancer the same. Those 1/3 of them who are PIK3, AKT, mTOR, PTEN pathway mutated, there you might actually add on something like a AKT blocker or a PIK3 blocker along upfront, and that may actually translate into a longer PFS because across the board, this PIK3 mutated tumors, be it ER positive, be it HER2 positive, be it triple negative, they don't fare that well with whatever conventional therapies we are giving. That is one takeaway from my end, and that was a study to look out for and observe and watch out for further updates. And second, yes, as rightly shown that this elacestrant, yes, for ESR1, there is a small subgroup. It's an acquired mutation. So under the pressure of AIs, so then we have to test it for the second line. That is for the second line. And the third one would be all said and done, immunotherapy does have its role in all the breast cancer, leave alone triple negative. Triple negative was a big unmet need. And there we had this keynote trial where they showed that it is very good in neoadjuvant. Also in first line, the Keytruda has got an approval. But same thing we can actually add on to the hormone receptor positive. But the problem with hormone receptor positive is we are spoiled for choices. We have so many target therapies. We have CDK4/6 inhibitors. We have excellent hormone therapies. We have something like this PIK3, PTEN also coming up, antibody drug conjugates coming up. And also on top of that, immunotherapy has to find its place. So, but the best place for immunotherapy in breast cancer, because whatever basket studies data we had available, was that it is useless, worthless in second line, third line metastatic setting. Whatever its use of immunotherapy in breast cancer, it is either in the first line metastatic or even in the neoadjuvant. So that thing keynote study which actually was presented first along with your immunotherapy, along with the neoadjuvant in the neoadjuvant setting of hormone receptor, has its own value because you might end up having more PAT-CR and you never know. Maybe that 10% difference in PAT-CR may end up with longer term follow-up of a 10% difference or 5% difference even in overall survival. Adjuvant chemotherapy got its approval just with 5 to 6% of difference in the overall survival in the long term. So why not accept this rather than saying that it's only for triple negative? We are spoiled for choices, I do know, but then there is scope for improvement everywhere because we are not curing 100% of our patients. At the best, we are curing 85 to 90% of ER positive operable patients as well. So 10-15%, there is an unmet need always in cancer. So with a very open mind, yes, that data is also looking very good. Yeah, that's what my comments are.
So as far as Debra study goes, I think it is actually a very strong data because to find a subset of leptomeningeal disease, which is uncommon, but which has very dismal prognosis, and the results that we have shown are quite impressive. So it's not like that there is no treatment for brain mets. For brain mets, we do have multiple treatments, starting from lapatinib. HER2 climb has already shown that it is a very potent regimen. But then even the regimen of tucatinib, capstabine, and trastuzumab, which has been tested in TBCR 049 study in a non-randomized phase 2 fashion. Again, there was CNS progression seen at a median of 6.9 months. And when you compare it with this TDXD, there was no CNS progression for a follow-up of almost a year. Median overall survival was just 10 months for this tucatinib-based regimen. And for TDXD, it is 13.3 months. So it does give us a very great option and gives us a hope that, yes, the patients who develop leptomeningeal disease do still have a chance. Now, this is not just about HER2 positive disease. There are plenty of patients who would be ER negative, PR negative, and maybe HER2 1+. That is TNBC patients who are actually HER2 low. So this drug works in that subgroup also.
So to my mind, this is a very promising agent. Yes, this is a niche use, but then we can't just brush it off saying that we have seen great results with TDXD in brain, so it should translate into leptomeninges. It doesn't happen this way. It doesn't happen. Intrathecal trastuzumab median overall survival is just for 4 to 6 months. For tucatinib-based regimen, it is just 6.9 months. Considering all these things, it does seem that TDXD probably is going to change the way we practice breast cancer treatments. So I think this was a very interesting abstract, and I will hand over the mic back to the organizers and my fellow colleagues for further comments.
Thank you so much, everyone, for making this discussion so interesting. Now, I would like to invite Dr. Jyoti Vadva for take-home message. She is a Vice Chairperson and HOD in the Department of Medical Oncology and Hematology at Paras Health, Gurugram. Over to you, ma'am.
Thank you, Anshika. Thank you, Dr. Vaid, for this opportunity yet again. So I will be summing up what we just heard. 4 interesting presentations, which we just heard, some of which would be practice changing, I think. So we saw the first presentation reporting the PAT-CR rates from the Keynote 756 trial. This trial dealt with patients with high-risk ER-positive, HER-negative early breast cancer, and it demonstrated that neoadjuvant pembrolizumab with chemotherapy did improve the PAT-CR rates when compared to chemotherapy alone. And the PAT-CRs were better to the tune of 24% versus 15% in the other arm. Now, furthermore, the improved PAT-CRs with pembro, they were seen across all patient subgroups. So irrespective of the disease stage, the lymph node status, and PD-L1 expression, the PAT-CRs did improve with the addition of pembrolizumab. However, the greatest benefit was seen in those that had node-positive disease at baseline, had higher PD-L1 expression, and were ER low, less than 10%. So this Keynote 756, I think, is important. Something happening in early breast cancer there, which is high risk, hormone receptor positive, and HER negative. Then we heard the presentation of a very small phase 2 DEBRA study, and it did report the efficacy of trastuzumab deruxtecan in both HER2 positive and HER2 low, as Gaurav just mentioned. So in both these subsets with advanced breast cancer with pathologically confirmed leptomeningeal disease. So a very select subgroup, but impressive results because the median OS was to the tune of 13.3 months, and no new safety signals were reported in this subset of patients. So an advance there with trastuzumab deruxtecan in leptomeningeal disease. The third presentation was on Tropion Breast 01 study, which reported, I would say, a potential new option, namely datopotamab deruxtecan, in patients who had previously been treated and were endocrine resistant, hormone receptor positive, HER negative metastatic breast cancer patients. And these patients, to note, had failed 1 to 2 lines of chemotherapy as well, and endocrine therapy, including CDK4/6 inhibitors. So this drug, though not available here, but seems quite promising. And the last talk was telling us about how to navigate endocrine therapy in ER-positive, HER-negative metastatic breast cancer patients. And we learned that we have various options here also. So especially the role of testing for ESR1 mutations with blood-based circulating tumor DNA assay to look for the possible role of drugs, not only fulvestrant, but newer molecules such as oral preparation elacestrant. We also saw new molecules like capivasertib in combination with fulvestrant, which is in fact now approved for tackling endocrine resistance in the presence of PIK3CA or AKT1 or PTEN alteration. So an important drug combination and approval in this subset, which is quite significant in terms of the proportion of patients belonging to this subset. And then we obviously have a role for continuation of CDK4/6 inhibitors beyond progression, as shown in the MAINTAIN and the PACE trial. So these were 4 interesting presentations, and I think they were all very interesting and informative. So thank you. Over to the organizers.
Thank you so much, ma'am. Thank you so much, ma'am. And thank you everyone for joining and making this masterclass such a wonderful and educative. Thank you.